So imagine trying to chisel a piece of drywall off a live high-voltage fiber optic cable.
Oh man, that sounds like an absolute nightmare.
Right, and if your hand slips by even like a single millimeter, the power goes out permanently.
Yeah, game over.
Exactly, no pressure at all. But now, imagine doing that inside a living, breathing human skull.
It is, well, it's the absolute definition of high-stakes real estate.
Yeah.
You aren't just looking at bone and tissue, you are looking at the literal wiring of human consciousness, sensation, survival, all packed into a space the size of a teacup.
Welcome to the deep dive. Today we are looking at an incredibly unique stack of sources you shared with us.
Yeah, really fascinating stuff you sent over.
Right, our mission today is to decode this fascinating set of handwritten medical documents. They're simply labeled ear notes 2433.pdf.
Which, to the untrained eye, just look like dense, hurried scribbles from a surgeon.
Totally, just medical jargon. But hidden in these pages is a thrilling roadmap to the microscopic geography of the human body, basically the head, the neck, and the airway. Okay, let's unpack this because we are moving from the sheer density of these medical scribbles to the incredible mechanical engineering of human anatomy.
Right.
And the intense risk-reward calculations these surgeons have to face every single day.
What's fascinating here is that this material isn't just a manual on how to cut. Any surgeon can physically make a cut, right? What we are looking at is a masterclass in when to cut and maybe more importantly, when to step back.
Oh, that makes sense.
It is a constant agonizing balance between preserving a patient's life and preserving what makes that life functional, the senses. Hearing, balance, speech.
Exactly. And surprisingly, we don't start deep in the skull. We actually start on the absolute surface.
Right, the skin.
Yeah, the very first thing we see in the notes is skin cancer staging.
Yeah.
You get these terms like Clark's level.
Which is super important.
Yeah, it grades the depth of the tumor from level I, just sitting up in the outer epidermis, all the way down to level V, down to the subcutaneous fat. And there's another metric called Breslow thickness. But why are we starting an ear and neck deep dive with skin?
Well, because the surface dictates the entire approach. This grading system determines the safe margins a surgeon has to take around a tumor.
Which can be big, right?
Yeah, it can range from 5 millimeters up to a full 2 centimeters. And if you think about it, 2 centimeter margin on your thigh is nothing.
Right, you barely even notice it.
Exactly. But a 2 centimeter margin on your cheek, or right next to your ear.
That is a massive chunk of your face.
It really is. That requires intense, complex reconstruction. So right out of the gate, we're establishing this theme of extreme spatial awareness. Every millimeter counts.
That spatial awareness becomes terrifyingly clear as we actually move from the skin into the ear itself.
Oh yeah.
There's a procedure outlined here called an automastoidectomy. And there's this highly evocative phrase, scribbled down mastoid misery.
It sounds awful just saying it.
It really does. It describes a condition where a patient has continuous, awful discharge from the ear after a previous surgery, right? So the surgeon has to go back in for a second look surgery to save vital structures and hunt down what are called pearls. Now, pearls sound nice, but in this context, they definitely aren't, right?
Not at all. Those pearls are cholesteatomas.
Okay, what are those?
They're essentially rogue cysts of skin cells that grow where they really shouldn't, right inside the middle ear.
Oh, wow.
And what they do is highly destructive. They literally eat away at the delicate bones of hearing.
Just consume them.
Yeah, so the surgeon has to go back into the mastoid cavity, which is that honeycomb-like bone right behind your earlobe, and meticulously clear them out.
And the endpoints of this surgery, what they call a cortical mastoidectomy, are absolutely wild to read.
They really are.
The surgeon has to navigate safely through this bony honeycomb until they hit these landmarks that sound like they belong in a sci-fi movie.
Right, like the thin dural and sinus plate.
Yes, and the incus shadow. And this is the one that really got me. They must literally skeletonize the vertical segment of the facial nerve. Skeletonize.
It's an intense word.
Remodeling a house with a sledgehammer is one thing, but using a 3mm burr drill to remove the scutum bone while trying to skeletonize a facial nerve.
Yeah, it's terrifying.
That goes right back to my fiber optic cable analogy. You are chiseling bone off the nerve that controls a person's ability to, smile, blink, or just move their face.
It's an incredibly delicate mechanical operation. And, if we look at why they are doing this, it's not just about removing the disease.
What else is it about?
They are rebuilding a highly complex acoustic machine. For instance, look at the details on tympanoplasty.
That's the reconstruction of the eardrum and middle ear.
Exactly. The precision is astonishing. They note that when placing a skin graft over a hole in the eardrum, it needs to overlap the perforation by greater than 2 millimeters.
Not just roughly, but very specifically.
Right. They have to navigate microscopic structures, named the facial ridge and the facial bridge. They're acting as structural architects, but working under a high-powered microscope.
But what I love is that the goals for that tympanoplasty are just so human.
Yeah, very relatable.
The notes say the goals are to eradicate the disease, improve hearing, provide a dry canal, and then wonderfully enable the patient to swim.
I love that part.
After all that terrifying talk about drilling near the brain casing and skeletonizing nerves, the ultimate goal is just to let you jump in the pool again without getting a horrific infection.
It totally grounds the entire procedure. The intense, almost frightening mechanics of the surgery are entirely in service of restoring a normal, functional human life.
So, okay, we've managed to reconstruct the middle ear, and the patient has a functioning eardrum. But what happens when the problem isn't the physical bones, but the actual nerves and fluids powering the whole system?
That's when things get even more complicated.
Right. That shifts us deeper into the delicate mechanics of balance and sound. And this is where we start seeing surgeons sometimes flat out refusing to operate.
Yes, the contraindications to stapes surgery. The stapes is that tiny strut bone, the smallest bone in your body. And there are specific patient factors in the notes that essentially serve as a giant red stop sign for any surgeon.
Yeah, you absolutely do not operate if it's the patient's only hearing ear, which makes total sense. You don't gamble with their last lifeline to the auditory world.
Exactly.
But you also don't operate if they are young children, and I found this really fascinating, if their job requires balancing or being in noisy surroundings. Why is someone's profession a deal breaker for ear surgery?
Because of the risk of catastrophic complications. When you operate on the stapes, you are knocking right on the door of the inner ear.
Okay.
You risk a perilymph fistula, which is a literal leak of inner ear fluid. You risk facial nerve injury, and interestingly, you risk a disturbance in taste.
With taste from an ear surgery?
Yes, the chorda tympani, the nerve responsible for taste on the front 2/3 of your tongue, actually runs right straight through the middle of your space.
Oh wow, I had no idea.
Yeah. So one wrong move, and food tastes like metal for the rest of your life.
That is wild.
So instead of risking surgery for someone with conductive hearing loss who still has a good speech score, it's highly recommended they just use a hearing aid.
Just avoid the risk altogether.
Exactly.
Though there are recent advancements mentioned if you absolutely have to go in, like SWIV, which stands for stapedotomy with incus bit fibroplasty.
Right, the mechanical bypass.
Basically a mechanical bypass for the broken parts. But speaking of broken systems, things get really intense when we move from physical bones to fluid problems.
Oh yeah, Meniere's disease.
Yes. I'm looking at this section on Meniere's, and there's a phrase here that I need you to translate.
Sure, go for it.
Idiopathic distended endolymphatic system. What on earth does that actually mean?
Okay, let's break that down. Idiopathic means we don't know exactly what causes it.
Got it.
Distended means swollen, and the endolymphatic system refers to the tubes of fluid inside your inner ear.
Okay.
So basically, mysterious, massive fluid pressure building up inside the balance center of your ear.
And the symptoms sound like an absolute nightmare. attacks of severe vertigo, ringing in the ears, tinnitus, and fluctuating hearing loss.
It is deeply debilitating. Imagine the room suddenly violently spinning just out of nowhere.
I can't even imagine.
And the treatment escalation is a really fascinating study in cause and effect. They start incredibly simple, a strict low-salt diet, and no caffeine.
Why salt and caffeine?
Because salt causes your body to retain water. If you reduce water retention systemically, you hopefully reduce the fluid pressure in the inner ear.
Right.
They also use a medication called beta-histine to improve blood flow to the area.
Okay, that makes sense. Basic fluid dynamics. But if that doesn't work, the treatments escalate to sci-fi levels.
They really do.
The next step is literally injecting steroids, methylprednisolone, and hyaluronidase directly through the eardrum. And the patient has to just lie there with their ear pointing up for 30 minutes to let it soak into the inner ear window.
Right, gravity does the work.
But if the vertigo is still uncontrollable, the last resort is a drug called gentamicin.
Yes, intratympanic gentamicin.
Hold on, I want to make sure I'm reading this right. Gentamicin is an antibiotic, but the text specifically highlights that it causes sensorineural hearing loss.
That is correct.
Are you telling me that if the vertigo gets bad enough, they inject a drug that they know might deafen the patient just to stop the spinning?
Yep.
They are intentionally sacrificing one sense.
This raises an important question about the hierarchy of human senses, doesn't it?
It really does.
As a healthy person, you might think, I would never trade my hearing for anything. But if we connect this to the bigger picture of what extreme vertigo actually is, it's not just feeling a little dizzy.
Right, it's way worse.
It is a total horrifying loss of spatial reality. You can't walk, you can't work, you can't even keep food down because of the constant violent nausea.
Oh, wow.
Between deafening a patient and leaving them with severe uncontrolled Meniere's, deafness is actually considered the more humane option.
That's crazy.
The gentamicin is essentially being used as a chemical weapon to kill the balance cells so they stop sending chaotic spinning signals to the brain.
Wow. That is heavy.
Yeah.
But on the flip side of that, you have BPPV, benign paroxysmal positional vertigo.
Yep.
And for this, there are no drugs, no surgery.
Right, totally different approach.
You fix it entirely with physical maneuvers. The Epley maneuver, the CMOT maneuver, and my personal favorites to say out loud, the 270 Barbic maneuver or the 360 yaw rotation.
They do sound pretty fun.
It sounds like a skateboarding trick.
Yeah.
But they're literally just rolling the patient around on a table.
Yeah.
How does rolling someone like a log cure vertigo?
Think of it like a marble trapped in a complex maze toy.
No?
In BPPV, tiny calcium crystals in your ear, otoconia, break loose and roll into the wrong fluid canal.
Oh, I see.
When you move your head, those crystals slosh around, tricking your brain into thinking you're spinning, and you can't reach in and grab them.
So what do you do?
You have to physically tilt the entire maze, the patient's whole body, in very specific sequences to roll those marbles back into the right pocket where they belong.
That is so cool.
It's a purely mechanical trick of gravity, contrasted beautifully against that chemical ablation they have to use for Meniere's.
It's amazing. One day the surgeon is a chemist, the next day they're solving a physics puzzle.
Exactly.
So we navigated the ear, but the deeper we go into the skull, the higher the stakes become. We start hitting tumors.
Yes, the acoustic neuromas.
Specifically acoustic neuromas, or AN. And the agonizing choices outlined here are just wow.
The pathology here is highly specific. Acoustic neuromas feature what are known as Antoni A and Antoni B cells.
Okay.
And if a doctor is looking at an MRI, they are hunting for a very specific visual, a globular mass that is hypointense on T1, but lights up or enhances when they inject contrast dye.
And there's a central puzzle here that caught my eye. It asks, why does a tumor on the vestibular nerve, the balance nerve, cause hearing loss?
It's a great question.
And the answer is a perfect lesson in confined spaces. Because that tumor compresses the cochlear nerve, the hearing nerve, inside something called the internal auditory canal, or IAC.
Right.
It's like a tiny subway tunnel where two trains are wedged tightly together. If the balance train swells up, it literally crushes the hearing train against the tunnel wall.
Exactly. And that crushing leads to a fascinating symptom called stapedial reflex decay.
What's that?
Normally, your ear has a built-in acoustic shock absorber, right? A tiny muscle that flexes to protect you from loud noises.
Okay.
But because the nerve is being crushed by the tumor, the signal weakens. The muscle flexes, but then it just gets tired and gives up, letting the loud noise blast through.
So you have this tumor deep in the skull, pressing on vital nerves.
Uh-huh.
The surgical approaches to get it out read like the ultimate, most terrifying pros and cons list ever written.
They really do?
Let me make sure I have this straight so we don't get lost in all the jargon.
Go ahead.
Approach 1 is translabyrinthine.
Why?
Pro, you don't have to pull on the brain, you can take out any size tumor, and the facial nerve is safe.
Right.
Con, you drill straight through the inner ear. It is explicitly called a hearing violating approach. Your hearing on that side is gone forever.
Correct. You sacrifice the ear to save the face and the brain.
Okay, approach 2, retrosigmoid. You go in from behind the ear. Pro, it actually saves the hearing. Con, you have to deal with a persistent post-op headache and an increased chance of a cerebrospinal fluid leak.
Yes, because you are opening skull closer to the cerebellum.
Here's where it gets really interesting, the third option, the middle cranial fossa approach, or MCF.
Ah, yes.
This is for small tumors, less than 1.5 centimeters. The pro is that hearing is beautifully preserved because you see the whole canal from above.
Right.
But the con, you're telling me to save the hearing in a tiny sub 1.5 centimeter tumor, they literally have to retract the temporal lobe of the brain.
They do.
And doing that risks the patient's speech and memory.
They absolutely do. The temporal lobe handles language processing and, memory.
Wow.
So the surgeon is playing a multi-dimensional game of chess here. The pieces on the board are the patient's ability to hear, their ability to speak, to remember who they are, and to move their face to smile.
The stakes are astronomical.
If they pull that temporal lobe back just a little too hard, or leave the retractor on for just a few minutes too long, the patient might wake up with a perfect hearing nerve, but they can't remember the word for apple.
That is terrifying. And the complications listed for these surgeries, it reads like a physiological horror story.
Yeah, it's not light reading.
Air embolism, where air gets sucked into the bloodstream. AICA, vascular injury, which is nicking a major artery that feeds the brain. Stroke, brain injury, and something called SIADH post-op.
Right. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone.
That's an alpha.
It basically means the trauma of the brain surgery causes the pituitary gland to totally freak out. It releases hormones that make the body dangerously retain water, throwing your blood sodium into chaos.
Jeez.
It emphasizes the sheer bravery required from both the surgeon and the patient. You are navigating the most vital real estate in human anatomy. There is no free lunch in skull-base surgery.
It's incredible. Now, from the microscopic delicacy of the skull base, the information shifts down into the brutal, vital pipeline of the airway.
Right, moving down the neck.
You're talking about subglottic and tracheal stenosis.
Which is essentially the narrowing or scarring of the windpipe.
Okay.
If the airway closes, nothing else matters. You have minutes to live.
Literally.
The damage here is graded using the Meyer-Cotton scale for subglottic stenosis, which is right below the vocal cords. And it breaks tracheal stenosis into 3 types. Cicatrical, which is soft tissue scarring, anterior wall collapse when the cartilage caves in, and complete stenosis.
And the tools they use to fix this narrowing are wild. They compare endoscopic approaches, going down the throat with cameras, versus open approaches, actually cutting open the neck.
Right.
For the endoscopic side, they use lasers. And the pros make sense. Extreme precision and hemostasis, which means the laser burns the tissue as it cuts, stopping any bleeding instantly. But the cons, thermal damage, restenosis, where the heat causes it to just scar back over, and this made my blood run cold and airway fire.
Yeah, if we connect this to the bigger picture, it is deeply ironic. Think about the environment. You have a patient breathing concentrated oxygen gas through an anesthesia tube inside their trachea. Oxygen is highly flammable.
Right.
You then introduce a laser, which is a source of intense thermal heat. If you aren't perfectly careful with your tools and your anesthesia gas mixture, the life-saving tool itself literally ignites the patient's airway from the inside out.
It's horrifying. So to avoid an airway fire or thermal damage, there's an alternative suggested, the microdebrider.
Yes.
Which is basically a tiny, cold, rotating blade that chews away the scar tissue and vacuums it up without using any heat at all.
Exactly. But if the stenosis is too severe, like if the cartilage rings of the airway are physically collapsing, the cameras, lasers, and microdebriders aren't enough.
So what then?
You have to open the neck.
And the mechanics of the open surgeries are just brutal structural engineering. If the airway collapses, the surgeons do something called a laryngo fissure.
Right.
They literally split the solid ring of the voice box and prop it open. And what do they use to prop it open? A rib graft.
Piece of bone.
We just went from the microscopic delicacy of saving a 1 millimeter hearing nerve to literally harvesting a piece of the patient's rib to prop open their windpipe like wooden scaffolding in a collapsed mine tunnel.
It's quite a contrast.
And they leave a stent in there for 8 weeks while it heals.
It is exactly like shoring up a collapsing mine. You widen the tunnel and brace the walls.
Wow.
And for complete tracheal stenosis, where a whole section of the pipe is totally ruined, they do a tracheal resection. They literally cut out the bad pipe and stitch the two good ends together in end-to-end anastomosis.
It sounds impossible.
Astoundingly, a surgeon can remove up to 3 centimeters of a human trachea, pull the ends together, and stitch it without needing extra procedures to pull the lungs up higher.
But the body's natural response to being cut and stitched is to create scar tissue, right?
Of course.
Which would just close the airway right back up. So to make sure that scaffolding doesn't fail, they deploy chemical weapons.
Right.
They mentioned applying a drug called mitomycin. Now, mitomycin is an antimetabolite. It's anti-neoplastic. It is literally a chemotherapy cancer drug.
Yeah.
Why are they putting a cancer drug inside a freshly reconstructed windpipe?
Well, because cancer drugs are designed to do one thing very well: stop cells from dividing rapidly.
Oh, I see.
In this case, the surgeon is essentially tricking the body. By applying mitomycin, it inhibits fibroblast proliferation. It pauses the rapid cell division of scar tissue formation.
So it forces it to heal slowly.
Exactly. They are chemically forcing the tissue to heal slowly and openly, so the tunnel they just rebuilt doesn't aggressively scar shut and suffocate the patient.
They were using every possible tool in the arsenal: mechanical scaffolding, biological rib grafts, and chemical inhibitors, all to keep a single vital tube open so you can simply take a breath.
It really is incredible.
It is a stunning amount of effort for something most of us do without thinking 20,000 times a day.
It requires a level of focus, anatomical mastery, and multidisciplinary skill that is, frankly, hard to comprehend.
Looking back over this entire journey through your sources, it really is a masterclass in human anatomy.
Definitely.
From safely chiseling bone off the facial nerve, to injecting gentamicin to cure vertigo by causing intentional deafness, to harvesting ribs to prevent an airway from collapsing.
The scope is massive.
The sheer mechanical, spatial, and chemical knowledge contained in these notes is staggering. So what does this all mean for us?
Well, there is one final detail in this material that I think perfectly encapsulates the reality of this field, and it leaves us with something quite profound.
Oh, really?
Yeah, it's buried near the very end.